Okay, I'm happy to welcome you all to our webinar today entitled Implementation Science in Action, Audit and Feedback to Improve Antibiotic Prescribing in Primary Care. This is our 10th webinar in the CAN AMS series, so happy you've joined today. I'd like to begin with some gratitude, certainly, in a good way, and just to state that the National Collaborating Centre for Infectious Diseases, or NCCID, is hosted at the University of Manitoba, situated on the ancestral lands of the Anishinaabe, Anishinaabe, Dakota, Dene, Nehethawak, and Ininawak nations. It's also in the heart of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work and are committed to working with our partners toward reconciliation. We would also like to acknowledge the Indigenous peoples of all the lands that we are on today. While we meet in a virtual platform, we encourage reflection on the importance of the land which we each call home. And we do this to reaffirm our commitment to improving relationships between nations and responsibility for increasing our own understanding of local Indigenous peoples and their culture. So those of you who've not been to our series before, this is the Canadian Antimicrobial Stewardship Webinars, or CAN AMS for short, where we invite leaders of antimicrobial stewardship to share examples of AMS strategies and interventions from their setting to help spread leading practices. We welcome a multidisciplinary audience, but that often varies in different events. The co-hosts of the series are AMI Canada and NCCID, and we're also supported by the wider collaboration called AMR Aware Canada, where we invite partners to unite and build awareness of the growing crisis of AMR, antimicrobial resistant infections in Canada, and what we can all do to help. So the coming events are posted on AMR Aware Canada, and if you're not familiar with our website, this is what it looks like. It's also a host site for the annual campaign during World AMR Awareness Week, but it also hosts this webinar series, resources, stories, and more. And if you haven't already signed up to get news, which includes news of coming events or webinars in the series, you can sign up on that page. So now just to some housekeeping. All attendees are on mute, and that's just to reduce background noise and any distractions. The chat box is disabled for participants. We're using that on the back end for the presenters. Please do enter questions in the Q&A box at any time. However, we won't be taking questions until after the presentation. And there you'll see that upvoting is active, so if you don't want to type in a question, vote for another question. The recording will be posted on the amraware.ca website in the webinars page when that recording is ready. So if you had to leave early or you want to show a friend, that's where you can point people to. Also, YouTube has our Center Infection account for NCCID has the series there. If you have technical difficulties today, email leah@ami.ca. And now I'll ask our moderator, Dr. Sarah Neal-Stramko, the co-scientific director from the National Collaborating Centre for Methods and Tools, to take the mic.
Great, thank you, Harpa. Good morning and good afternoon, depending on where across the country you're situated today. And just taking a moment to welcome you to today's webinar on implementation science in action. Thank you for joining us. As Harpa said, I'm Sarah Neal-Stramko. I'm the co-scientific director of the National Collaborating Centre for Methods and Tools. And it's really my pleasure to moderate today's session. And I'd just like to take a moment to acknowledge that McMaster University, which is the host of the NCCMT, is located on the traditional territories of the Mississauga and the Haudenosaunee nations, and within the lands that are protected by the Dish with One Spoon Wampum Agreement. So as Harpa said, this webinar is part of the Canadian Antimicrobial Stewardship webinar series that's co-hosted by the NCCID and AMI. And this series really shares some great practical examples of evidence-based antimicrobial stewardship interventions from leaders across Canada with the goal of inspiring actionable steps to help slow the rise and spread of antimicrobial resistance. And today's session is going to focus specifically on implementation science and how implementation science can strengthen antimicrobial stewardship. And today we'll talk specifically about audit and feedback as a case study for improving antibiotic prescribing in primary care. So we all know that there's an abundance of research that helps us to discover what works, and that leads to new guidelines, better ways to prescribe, tools to reduce unnecessary use. But we also know, unfortunately, that in reality, we don't always see these research tested interventions reliably showing up in day-to-day practice. There's been some different studies that, the numbers sort of vary, but it takes about 10 to 20 years or sometimes even longer for strong evidence to become routine practice. And that sort of no-do gap is the aim, is the focus of implementation science. So it's really the study of how to actually put evidence-based practices into real-world use faster, more reliably and equitably, and in ways that last. And so audit and feedback, which we'll be hearing a lot about today, involves comparing clinicians' prescribing practices to peers or guidelines and providing that sort of more personalized, actionable report. And there's really strong evidence that it can be an effective and scalable intervention to reduce antibiotic use. And we'll hear lots more about that in today's session. So we'll go to the next slide, please. So just quickly, our learning objectives for today. By the end of today's webinar, we hope that everyone is able to identify common barriers and facilitators to appropriate antibiotic prescribing in primary care settings. We hope that you'll all be able to describe the role of implementation science in improving the uptake and effectiveness of antimicrobial stewardship interventions. Be able to explain how implementation science approaches can be applied to peer comparison and feedback interventions in primary care. And lastly, be able to explain best practices in delivering personalized antibiotic prescribing, peer comparison feedback. So we have two excellent speakers joining us today. First, Kevin Schwartz is the division head for infectious diseases at St. Joseph's Health Centre in Toronto and the co-medical director for antimicrobial stewardship at Unity Health Toronto. He is an academic infection control and antimicrobial stewardship physician at Public Health Ontario and an assistant professor at the Dalla Lana School of Public Health at the University of Toronto, also an adjunct scientist at ICES. And his clinical area of interest is adult and pediatric infectious diseases, tuberculosis, and tropical medicine. And his research interests focus on antimicrobial resistance and antimicrobial stewardship, with a particular focus on improving community antibiotic use to slow the emergence of drug-resistant infections. Next, we will have Noah Ivers, who is a family physician at Women's College Hospital Academic Family Health Team, and who also leads a research program in implementation science at Women's College Hospital. He is a full professor in the Department of Family and Community Medicine at the University of Toronto and holds a Canada Research Chair in the implementation of evidence-based practice. Noah's research focuses on the use of data to drive evidence-based, patient-centered improvements in healthcare, and he has conducted multiple pragmatic randomized trials, systematic reviews, and qualitative work on health services and quality improvement interventions. And he is presently the scientific lead of the Office of Health System Partnerships in the Department of Family and Community Medicine at U of T. So we're very fortunate to have these speakers today, and I will turn it over to Kevin to get us started.
I think actually I'm going to go
Oh,
first,
I'm sorry.
not to confuse everybody. But yeah, I'll pull up my slides. I am always a little bit taken aback by getting introduced so formally. I'm not a particularly formal person. These are my conflicts. They are, basically empty pockets. If somebody wants to provide me something to fill those pockets, I'm willing to listen. But as related to this talk, there's nothing much to talk about. Other than the fact that I am influenced by some or many of the excellent researchers who have come before me in this space. And so I suppose I have some intellectual conflicts, but that's not what this sort of slide is meant to be. before we dive deep, I think it's really important to understand what's going on in primary care. And you've all seen the headlines that we have over 6 million Canadians without access to longitudinal comprehensive primary care. You also remember learning at some point how important high functioning primary care sector is to the overall effectiveness and efficiency of a health system. So you all kind of have a sense that this isn't a good thing. Perhaps you don't have a complete sense of why this has happened or what's people are trying to do to address it. And I think anytime we try to explain this in sort of a minute or less, we're bound to oversimplify. And in fact, it's quite complex. But the basic story is that the nature of primary care has gotten more and more complex over the years. Patients themselves have been more complex. There are more guidelines, more drugs, more this, more that to manage. Patients don't stay in hospital very long, so they're kicked back to primary care to sort out all the details, for example. And so as the job has gotten more and more complex, increasingly, family docs have chosen to do other things than office-based comprehensive longitudinal primary care. Increasingly, they're choosing to work in hospital as hospitalists or in emerge or in long-term care or some sports medicine or perhaps doing Botox a day a week or what have you. And that breaks up their week and makes their cognitive burden a little less, maybe, to help them manage their burnout in an understandable way. But the result of that is that whoever's left doing the office-based stuff has even more patients to look after, and we end up in this negative feedback loop that we now have to break. So that's, if we want to talk about making change in primary care, it's really important to understand the context that we're stepping into. I can, make it an even shorter explanation by saying this is, a picture of me in the middle of clinic, and it's a picture of most family docs in the middle of clinic. It's just not an easy environment right now to make change in because everybody's kind of already hitting their heads against a wall. If you prefer data rather than anecdote, there's this excellent article that shows that, for a full-size practice, this is in the States, they have larger panels typically than primary care clinicians would in Canada, but the point still stands. In order to enact the core sort of preventative and chronic disease guidelines, would take more time in office than there is. And it's basically estimated that the panel of 2,500 would take more than 24 hours a day every day to manage if you model it out. And so you end up with family docs kind of looking like Dr. G here. So that's the context, and it's just a little bit of necessary preamble before we get into the core of the talk. The crux of implementation science is advancing methods related to making change. And as I said before, if we're going to make change, we really need to understand the context in which we want to make that change and think about how we're going to make sure our interventions, our strategies for making change are fit for purpose. So a little more data for you. We've been lucky enough to be involved in quite a few studies around antibiotic prescribing, including some qualitative work. And there are some quotes here that I stuck on this screen that I'd encourage you to I'll just shush up for just 30 seconds and you can skim them, please. So you can keep reading while I speak, but we have some themes here that if you spent some time with the literature or spent some time in primary care would feel familiar. You have docs saying more or less they know what the guidelines are, but they struggle to implement them. That's that implementation no-do gap that Sarah was talking about before. And then they go on to explain some of the reasons they think are going on about why they struggle with that. For instance, it's a patient that's prone to go to the next doctor and ask anyways, so why not just give in? Or it's a patient I don't know and they don't, I haven't built trust over time. And if I had, that would be easier. Or I'm in a rush and it takes longer, or somehow it feels safer to me to prescribe than not prescribe. Then that's where we get into the meat of the issue. These are the things that we can target for change. All right. So frequently, when we know that there's a big discrepancy between what's happening in usual care and what ought to be happening, it is natural for us who want to make change to develop a report card, give it back to people and say, hey, there's a gap here. And then, we hope that that will lead to the solution. And what I can tell you from spending more time thinking about, I guess, report cards, which is another sort of a synonym for audit and feedback, than probably any human should, is that we really have to think deeply about the ways in which we might hope this will work, and be explicit about the proposed mechanisms of action so that we can build an intervention that's more likely to work. What do we know about how well audit and feedback works in general? Well, we actually have tons of data across tons of contexts and tons of topics. And we've summarized and synthesized that data in a Cochrane review last year, which took me literally a decade to get done, and a cohort of authors from around the world to whom I share my eternal gratitude. What you see on the screen here is using different units of measurement, ways of understanding what kind of impact audit and feedback had in these trials for the different outcomes that the audit and feedback was trying to improve. Not always was the audit and feedback trying to improve antibiotic prescribing, although that is a very common focus in these trials. And Kevin will talk more about what happens when we zero in on those studies in a little bit. But what I want to do right now is just focus your attention, first of all, on the blue diamond that is the meta-analytical result. In general, audit and feedback leads to benefit when tested across hundreds of trials. But now I'll have you shift your attention to the gray circles and just highlight that the meta-analytical result hides a huge amount of variation. Audit and feedback is not guaranteed to be benign. Sometimes you can make care worse. It's hard to think through how that might happen, but we could imagine some scenarios where you get people so mad that they, tune you out or that sort of thing. And we see it in the literature, which just goes back to emphasize what I was saying before, that how we do this really, really matters. Thinking through the mechanisms of action really, really matters so that we can do it as well as possible and end up, whenever we're taking on this strategy, hopefully with some gray dots towards the far right. That is to say, the big, helpful, positive effect. So what did we learn from the review about which kinds of approaches lead to bigger effects? Well, I'll skip you from having to read the multi-hundred-page review and summarize the conclusions here. Yes, in general it works, but there's a lot of heterogeneity. That is to say, variation in effects. It works better when you add some co-interventions, which we can talk about a little bit. If we break down the elements of audit and feedback into three parts, there is how do we measure? That is the audit. How do we present the data back, the feedback? And how do we help people take action on that data as the third part? We can see there's some best practices associated with greater effects highlighted on this slide. And I want to just highlight a few of them for you, emphasize a few of them. One of them is that it is much preferable to measure somebody's own performance rather than the performance of their organization or their team or their institute or whatever. Because intuitively, you can understand this. It's very easy for a person to say, well, I'm better than that. That must be driven by that guy over there, that bad score. And it's much harder for them to do that kind of thing if you give them their own data. The other thing that I want to emphasize is the idea of including in some way, shape, or form a local champion. The goal here is that you immediately engender some amount of trust in the data and in the feedback. If you don't find a way to engender trust, people are likely to offer some comment about how the data aren't valid or don't apply to them or something like that. We'll get a bit more into that in a moment. And then, what we think is very important as well is making sure that we're comparing people not just to the overall average, but to some sort of target, usually made up of top performing peers. And peers is a key word here. They want to feel like it's a fair comparison. So it really should be folks seeing patients similar to the patients they're seeing or working in contexts similar to theirs, if you can. The reason why we don't want to compare just to the average is that if the average is not excellent, and somebody is already performing slightly above average, you're going to encourage implicitly regression to the mean. And if the mean is not excellent performance, this is one of the ways we can make care worse with audit and feedback. Okay. But there are more details to think about. And if there's one takeaway point you'll get from me out of this, it's really that that's where the devil is. So I mentioned some predictable things that people will say if you give them feedback, and a lot of that's around the data. This is things that I actually heard in another qualitative study that I did, perhaps a little more than a decade ago, but they're the sorts of things we continue to hear. And if you haven't heard something like in the theme of, those data are no good, or my patients are different, then you haven't done enough audit and feedback to clinicians, because I guarantee you will hear something in those themes. And if you haven't heard something in the third common theme, which is something along the lines of, I'm already trying my best, I don't know how to do better, then I would posit that not only have you not done enough talking to people or audit and feedback projects or putting the two together, but you haven't gained enough of their trust when you talk to them for them to admit that very common truth. And what that tells us is that when we build feedback and we think about how to measure things, we really need to help people through the validation step so that they trust the data, as I mentioned before. And we also really need to think carefully about whether, if we just show them the gap, are they going to know what to do next? Or do we have to hold their hand a little bit or give them some ideas about how to get a better score next time? There is some really, really helpful theory in the literature about this. This is a friend and colleague from Manchester, Ben Brown, who put out something called the clinical performance intervention theory, clinical performance feedback intervention theory. And I'll just draw your attention to the bottom, where if people start with a goal to, prescribe antibiotics according to the guideline, and then they get some feedback, and we actually get them to look at that feedback, number 4, interaction, that's where you have that step that's going to happen when they respond, some sort of verification step. And if they have the opportunity to say, well, this data are no good, they don't have to bother doing anything else. The cognitive burden goes away and they can ignore it and get on with their life. But if you found a way to convince them the data or the gap that you're showing them is real, and you get them to accept that gap is real between where they are and where they want to be, then you start to head towards an intention to do something different. And you can enable that by convincing them the thing to do different is not just trying harder, because that's not a sustainable way to improve. You can offer them some set of approaches that can help them get a better score, then you're more likely to avoid the unintended consequences. Now, informing all that blue stuff at the bottom is a bunch of mechanisms, which in turn are informed by the context and the recipient and the way you've designed the feedback. But I just wanted to lay that out for you there. And now sort of queue up, while I leave my sort of some of my favorite quotes up, I'll queue up Kevin to talk more specifically about how we've applied the broad literature about audit and feedback to do a series of studies where we actually have made care better around antibiotic prescribing in primary care. Kevin?
I am here. Thank you, Noah. That's great. Let me just get my slides going. Hopefully that all looks good. Um, and so, yeah, it's a great introduction, and I appreciate being invited. As mentioned, I'm an infectious disease doctor, and Noah and his colleagues and predecessor, Jeremy Grimshaw, have been kind enough to and sort of invite me into their world and really, I think, help propel this work and to make it impactful. I also don't have any conflicts, and we've gone through the objectives already. And I'll breeze over the introduction because I think this is a audience that is probably very engaged in work related to AMR and antimicrobial stewardship. But antimicrobial resistance described as a slow tsunami that threatens to undo a century of medical progress. I often like to explain it to, especially ID sort of micro groups, that this is not just about prescribing antibiotics for infections or common infections. It really impacts across the healthcare system. Advances we've made over the last 50 years, from more looking after more premature babies and more advanced chemotherapy and cancer treatments and more organ transplantation, all of these conditions and advances really require us to be able to treat common complications, which are mostly bacterial infections or commonly bacterial infections. And it has broad impacts into a lot of these healthcare system advancements. There is substantial, especially global mortality from antimicrobial resistance. Some nice work done globally to try and sort of predict and model this from the available data. And I find this often helpful for policymakers in terms of the burden. So the attributable deaths to bacterial drug resistance in 2019 was almost 1.3 million, which is more than HIV, which is more than breast cancer, and more than malaria globally. So combined is a major burden of illness and death. This is a report done by the CCA in Canada back in 2019, which tried to put some Canadian sort of context and numbers on it. So at the time they did this, 26% of infections were already resistant to first-line antimicrobials, and that was projected to increase to 40% by 2050, which has substantial economic impacts of $388 billion of cumulative decline for the Canadian GDP. And in Ontario specifically, this averages about 6 deaths per day attributable to antimicrobial resistance. And a lot of this is driven by overuse of antibiotics. And so this is a study that we've recently done that is under review in Ontario, where we have data for patients over 65, where we use a lot of antibiotics. And so just to highlight a couple things from this, that we actually have seen some overall decreases over the last 23 years in terms of the amount of antibiotics we prescribe per population. And we've seen some improvements in the appropriateness. You can see the green line going up a bit, the red line going down, sort of ignoring the COVID blip. But still about 37% of antibiotics appear to be being prescribed for conditions where they're never appropriate. These are viral conditions, upper respiratory infections, bronchitis, and other things where almost never antibiotics are needed. So lots of room for improvement still in this space in terms of how we prescribe outpatient antibiotics. And it's complicated. Noah talked about this. I just want to re-emphasize a few points, but this is not a problem of like, here is a guideline, and then doctors be like, oh, I didn't realize I'm not supposed to prescribe antibiotics for this condition, because they all know that. The family doctors know this. They give us feedback when we do this work that like they don't need education about when to prescribe antibiotics, because that is really only a really minor part of it. It's a key part that there's guidelines and that they know what to do, but it's generally not a knowledge gap. And what we have are a complicated mix of patient factors, prescriber factors, and health system factors that lead to overprescribing or unnecessary prescribing of antibiotics. So things like time constraints within a busy practice, you know, experience and training of the physician, but often habit and anxiety, a fear, just worrying about something bad happening, sort of medical legal type risk. Diagnostic uncertainty is some of the issue as well, but often it's even less that. Often doctors have a sense about what the diagnosis is or how likely are to need antibiotics, but diagnostic uncertainty is part of it. And then the patient factors of patient knowledge and understanding, perceived expectations or expectations from the patient are also important contributors. And for any given encounter, it could be different mixes of these variables. So it's a complicated problem with not one solution, but which is why the using these behavioral science technique and the implementation science principles are going to result in actual better chance of improvement and change. And so this is the summary that antibiotic audit and feedback works. I'm going to show you some of the data that we've done and that we've summarized to demonstrate this, and and how and why it works. But we've shown that it does. So this is a study that we did back in 2022 of a mailed feedback letter to family physicians in Ontario. We mailed this letter to over 5,000 family docs that weren't otherwise getting feedback by any mechanism at the time. And we had about 4,000 receive the letter, and just over 1,000 of the docs were in our control group that did not receive the feedback letter. And then this is an example of what it looked like, the first page, that it's personalized to the doctor. It has a central figure that has their data with an achievable target highlighted that, if they do open the envelope, they basically can see what what we're asking of them and showing them, hopefully pretty quickly. And the bottom line is that the overall comparison of this trial, the intervention group compared to the control group, was effective. There was a 5% overall reduction in antibiotic prescribing, 11% reduction specifically in unnecessary prescribing, 15% reduction in prolonged duration prescribing, which we included some education and materials within the letter. We had tested a few different variations of the letter in this as a factorial trial, which didn't make any additional differences, but the overall intervention was effective. Building off of the work that Noah and that group did on the Cochrane review, we pulled out all of the antibiotic articles, the antibiotic prescribing articles from that Cochrane review, and did a separate meta-analysis from that. We separated it here by the outcome that these studies use, so whether they looked at overall prescribing or different outcomes. And overall in the meta-analysis, this intervention was effective. So there was an 11% reduction in overall prescribing, 23% reduction when they looked at specifically unnecessary or inappropriate prescribing, 13% reduction in prolonged duration prescribing, and 17% reduction in the studies that looked at antibiotic selection or appropriateness of the drug. Again, you can see highlighted from Noah's study, there's a fair amount of heterogeneity. There's a fair number of negative studies, but when we pool this all together, it is effective. But as he says, the devil's in the details, like how this is designed and how you are doing it is likely going to be the driving factor of whether or not it works. But overall, we've shown that it can and does work. And it's very cost saving. So this is from the Ontario data and study. We did an economic evaluation that is in press now and will be out soon. But for every $1 we spend in Ontario mailing these letters, we save the healthcare system about $9. And that's mostly related to the reduction in drug costs, but we incorporate things like healthcare visits for antibiotic side effects and healthcare visits for potential undertreatment of infection and other things within our administrative data. And combined together, this is a cost-saving intervention. So why does it work, or what makes it work? So, we want to link the data to the desired behavior. And again, Noah highlighted this, but in terms of antibiotics, we really want it to be hopefully linked to the data to what we're asking docs to do and how to do it. We need a benchmark or a peer comparison that is achievable, but also that is not the mean. And I think this is really important when we're designing these interventions. The mean antibiotic prescriber is not appropriate. And I showed you that earlier slide of 37% of antibiotics are prescribed for conditions that are never appropriate. The mean is not the goal here. We want to reduce the overall population average. And then when we're doing peer comparison, we really need to give a lower than the mean target if we're going to move the population. We need a central figure in display. There was a nice study out of Australia that really showed this, that docs need to understand the data within seconds. We've shown from our previous work that maybe only about a third of docs even open the letter, and likely a lot of them do not spend the time to read it all. They need to open it and be able to see what's being asked of them for it to be impactful on the population level. Because docs are busy and most of them are not going to spend a lot of time engaging with this. The feedback needs to be facilitated in some way. It needs to be repeated. Docs want to see their progress. And if there can be some sort of peer or group discussion about their data, that will also, facilitate some change. So I'm going to talk a bit more about some national efforts and what's happening, sort of building on the work that we had done and the trial that we had done. We've called this Can Build AMR. This is a national or research funded CIHR funded research program where we're trying to expand antibiotic audit and feedback in primary care to more places across the country. So together with our national group, interviewing family docs, we built on what the previous Ontario intervention to design a letter, and then it's shared with all the provinces, and then it's sort of revamped locally for each local purpose or the way that each province wants to do the intervention. But just to highlight, it has those principles of what we hope are respected organizations, personalized data to the individual, a central figure that's sort of easy for them to see the data, and then some context about why they're receiving it and what it means. The rest of the letter is our 2 double-sided pages, the way that we mail it out in Ontario. It has tools and resources for choosing wisely, some communication tips. We also give them a table on antibiotic durations, which we've shown as an easier to fix problem with an education gap. Just educating docs about what evidence-based durations are results in a pretty substantial change. And then we have it co-signed by some respected figures from Choosing Wisely Canada, the Ontario Chief Medical Officer of Health in Ontario, and then a family physician lead from the Ontario College of Family Physicians. And this is the Ontario specific version. Just to sort of briefly highlight what's happening as part of Can Build AMR across the country is that we've had really good uptake and engagement from across the provinces and territories. BC group through BC CDC is engaged in this, and they're mailing letters this month that are going out to docs of a slightly modified version from what I showed you. Alberta has an online dashboard, and we worked with them as part of our Can Build group to revamp their dashboard, really try and get those principles of implementation science into the way that they're doing feedback. And they're focusing on antibiotic durations, but it looks really good, and that was released in November. Saskatchewan and Manitoba are going to be mailing similar letters to the Ontario, and that'll be happening, this calendar year most likely. I mentioned the Ontario one, which we've done, and we did it as part of a trial, which I'll show you on the next slide. The Quebec group is going to likely add antibiotic indicators to an existing dashboard that they have for feedback to docs there. Again, incorporating these principles. And Newfoundland is also planning on mailing a letter. The other provinces, and we have some engagement from Nunavut, although it's been a bit of turnover. But there are other areas are working towards the feasibility of potentially doing an intervention as well. So in Ontario, as I mentioned, we did it as a trial to try and test, like, is there a way that we can improve this? If we change the data that we give docs, because, as Noah pointed out, we get very repetitive, similar feedback about, docs questioning and sometimes very legitimately the data or the comparison. So we know that audit feedback is more effective when the data is more directly connected to what we want the behavior change to be. So, but on the converse, if we try and give them more specific data, we incorporate diagnosis from billing claims, which is how we'll do it in Ontario, and many other areas we're using administrative data. Are we going to even decrease the acceptance of the data? Is it going to be less accepted and then actually less effective than we've shown from giving overall antibiotic prescribing? So that's what we did in Ontario. We took those two concepts. So the one on the left is similar to what we've done in the past a few times now, where we give overall antibiotic prescribing data compared to their peers. And the one on the right here is unnecessary prescribing. So we use the billing claims and we tell them what proportion of their visits to a patient with a likely respiratory viral infection are getting antibiotics. And this should be probably, pretty close to zero or much lower. And we mailed out these letters in a randomized fashion to docs, about 8,000 docs, to see if it makes any difference, to use a bit more of the data and to try and connect it more directly to the behavior. So if you want more information about CanBuild, Choosing Wisely Canada hosts our website, which is fantastic, and you can check it out. We have background about the study, docs that are getting the letters. We have appendices and additional information about the data under the region section, and just links to additional resources and references for people interested in audit and feedback, or for family docs, primary care prescribers that are receiving these interventions. There's, of course, some limitations to the way that we do this, especially, there's more focus on Ontario, but, docs often ask for, like, well, can you just tell me which specific ones I'm doing wrong? Or, and this is not the way that it can work. It's basically high level. It's over a year of data. For both privacy reasons and practical reasons, you can't drill down with this sort of data into it. But really, the goal is just to get docs to reflect on their prescribing, use the peer comparison that gets them a bit more engaged into it, and sort of reflect on often what they know, but to use the tools to see where they can make improvements. We have a limitation in Ontario that just the data is limited to 65 plus, which is an important limitation, although just to highlight, what we did is we took our original trial and we analyzed it against another data set that has all patient ages in it, related to antibiotics. We actually showed that the outcomes were very similar. So the effect size, the reduction from the feedback for physician prescribing was actually very similar across different age and sex groups, even though the feedback and the data that we give them is 65 plus, which is good. We think that the data we're giving them and the materials are applicable, obviously, for all of their prescribing. And it seems like it's changing their behavior across these different groups. The other feedback that we've heard, and this was, from the peer reviewers when we submitted the manuscript and others, is that, well, how do you know your reduction is actually good, right? It's a small reduction of 5%. And, I think we can probably safely reduce antibiotics by 25, if not up to 50%. And so it's very likely that it's an appropriate reduction. But we did look at this as well. This is also not yet published, but we looked at bacterial complications between the two groups of the intervention group that had lower antibiotics and the other group, and we found no signal or suggestion that there was any undertreatment of antibiotics that led to any bacterial complications requiring visits to hospital. And so, again, encouraging that there's no detectable or serious harms from unnecessary reductions in antibiotics, and likely supports that we're seeing reductions in unnecessary antibiotics. So just to summarize, antibiotic prescribing feedback for family physicians is effective at making small reductions in antibiotic use. These are not huge reductions. It is not where we, I think, need to be in the end, but we've shown it to be effective clinically and statistically significant on a population level. This program saves the healthcare system money with no detectable harms. I really think it should be a no-brainer from a policy perspective, and we've been trying to, our next steps as part of CAN bills is to try and encourage this across the board to see if we can integrate this into policy and stop using research money to do this when it's really robust evidence base for this. The data are confidential to the physician. They're not shared with anyone except the recipient. Is not meant to be punitive, and it's really meant for self-quality improvement. Um, Feedback is really one component of an AMR strategy, and I think it's important to highlight. It's what I'm interested in and what Noah's interested in, but this is a multifaceted, complex problem. We need better surveillance of AMR and AMU. We need infection control. We need a vaccination policy, which reduces antibiotic use and reduces infections. We need public education. And right now in Ontario, we have none of that directed related to AMU and AMR. Some areas in the West Coast are doing a bit better with this, but we need more of that to educate the public. We need antimicrobial stewardship for other prescribers. Dentists prescribe about 10% of antibiotics. Again, they're better at this in BC, but in Ontario, we have not been able to initiate a program yet, although we're working on it. Pharmacists can prescribe antibiotics pretty much across the country now, and we need programs that are related to that and supporting pharmacists in appropriate antibiotic prescribing. Nurse practitioners as well are important community prescribers. And again, in Ontario, we've not been able to reach this group because of our data access issues, but these are all important components of it. It's not just family doctors, but family doctors prescribe about 2/3 of all antibiotics and an important group we focused on. I was going to make a plug as well for this AMI PHAC Canadian antimicrobial prescribing guidance. If you're not aware of this, there's a link there. You just download the First Line app, and really important to sort of spread the word, I think, to frontline prescribers as well, that this guidance is out and is going to be updated with more conditions forthcoming. So an important tool to support appropriate antibiotic prescribing. And with that, I'm done. There's the websites there, Choosing Wisely, and the First Line app, our email at Public Health Ontario. And I think we have some time for questions. Noah and I are happy to answer any. Stop sharing.
Great. Thank you both. We do have about 12 minutes for questions, so I'm sure there's lots after those great presentations. So thanks for giving us such an in-depth overview of both the research and then the practical side with the tools that you've developed. So I will keep my eye on the chat here. I don't see any questions coming in yet. Harpa, can you see anything on your end?
Sorry. No, I can't. Just a prompt for people. My Q&A box was hiding in the more section. So if you want to hit that more button on Zoom, if that affects you too, you can see the Q&A then. So that might be one barrier, but we'll give it some minutes and let people
Can I
ask
see
questions.
one easy question from Tara? If you can please share the links on your last slide, Kevin, in the chat, or if there's a way we can share them after the webinar, I'm sure we can make that happen. Great. Okay, and we do have another question that has come in. Wondering if you can share any specific strategies that have worked to gain providers' trust and support when doing any audit and feedback with the increased workload and information overload that can happen sometimes.
Yeah, I think this is a complicated question to answer, briefly. But I'll try just to leave space for Kevin also to respond and also other questions. What we have done is first make sure that there are logos and signatures of trusted, sources. And So that's a starting point. That signature from the president of the Ontario College of Family Physicians, we think is an important thing. To leverage the technique of having a credible source and a trusted source. The literature is full of trials where a local champion is used to sort of facilitate the feedback or facilitate the delivery of it. And that can help too. And then the other thing that Kevin mentioned is that in our projects, always we emphasize the data are confidential and for quality improvement only. And I think these are important starting points to address trust.
Great. Thank you. Kevin, did you have anything that you wanted to add to that?
No, I think no. I mean, hit the nail on the head with what we've tried to do, and I think we've, um, there's a lot of different ways that you can do this. So other jurisdictions, for instance, send feedback through the regulatory college, and look, we've intentionally not done that in Ontario to really just try and focus on the quality improvement focus, and that this is not punitive, like no one's getting in trouble for prescribing antibiotics. This is really about supporting docs to do the best care that they can do. And we've done talks for the family doctor group and just try and and emphasize these points that nobody goes to work thinking that I'm not going to prescribe appropriately. Like everyone in every counter, and they reflect that back to us that I'm doing the best I can. And so it's really important that I think it's framed in a way that recognizes that you're already doing the best you can. But it's about, often I think the way that this works with antibiotics, it's a simple reprioritization, right? Like, oh yeah, okay, I guess this is kind of important. That carries over to some encounters in some dogs, and we see population level impact. So again, it's not groundbreaking changes, but it's really just trying to get them on board with that idea.
Great, thank you. A few other questions have come through. Question or maybe a suggestion is whether we could partner with Ontario Health to get the list of other healthcare workers like nurse practitioners, pharmacists, etc., to send the surveys to.
Yeah, I mean, I can comment briefly on the data components. So Ontario Health does my practice reports. They get the data the same place we do, which is ICS or the administrative data. And so in Ontario, CPSO, the physician college, has the data linked at ICSS, and we can identify physicians. The dental college, the pharmacist college, the nurse practitioner college, that data is just not linked and available with a D to be able to identify who the prescriber is. We actually have several projects working with the colleges, like the pharmacist and the dental college, to do that work to link the data. And then my hope is that within the next years, it will be available, and then we could do these sorts of things. So that work is in progress. It's just the problem is this: no one's done that linkage work yet to link the data to our administrative data sets.
And that data linkage, well, sounds simple. There's many, many pieces that have to go on behind the scenes to make that happen, I'm sure. Great, thank you. A few other questions have come through. Has there been any discussion about review of antibiotics on public formularies and what criteria for coverage should be used and duration of coverage?
I can speak to that. So, I mean, I think just it comes to there's a lot of different ways to do stewardship. And, especially the hospital sort of stewardship framework is much more established. But when stewardship started, it was very much formulary restriction. This was the big thing that people thought was effective. And actually, we've removed all of that in our hospital. We don't do any of that anymore because I think there's better ways to do this than restricting the way that, prescribers have access to and fund certain drugs. And so a lot of it can think of carrot or stick approach. But I think if we can do this work well with engaging the prescribers with audit and feedback, implementation science, education, and I think we can probably get to a better place than trying to do formulary restriction. It does work, and at least short term. We did that, for instance. on the ODB restricted fluoroquinolones, back in I don't know if it was early 2000s or when they actually implemented it, maybe it was earlier. And we did see a large decrease because it's one additional administrative burden. You have to put in the LU code to get it funded in Ontario. And it did work. There was a reduction, at least temporarily, in fluoroquinolones. But again, I think there's better ways that we can do it, and we've shown that it works the other way. So I just don't think it's a necessary way to do stewardship.
Thank you. Okay, another question from David Patrick, musing about where this can go in the very long term. We can obviously consider repeating the intervention at intervals, but do you think there will be some point where we will see diminishing returns?
You want to go first, Noah?
David, thanks for being here. Sort of always thrilled to get to interact. I think that would be a great problem to have, probably, because we'll get diminishing returns when there's less room for improvement, I would assume. But we haven't seen it yet. Kevin's done these cycles of randomized trials in Ontario, and we keep nudging things forward. So, we ought to keep doing it. My guess is that if we hit some sort of plateau in a given outcome, we can shift what the emphasis of the feedback is focused on.
Yeah, I think the opposite is probably true for now, in that if we stop doing it, we're going to revert back to what it was right before we did the intervention. It might take a year or two, but it'll revert back. And there's a fair amount of data showing that the impact decreases over time. So I think we need to keep doing it to even just to sustain the small effects that we have. Are we going to get to a point where we're using so little unnecessary antibiotics that this is not going to be necessary? I think that, maybe that's the dream, David, but I don't think we're there. There's interesting experience in some of the Scandinavian European countries where they use, some places half the antibiotics we do on a population level. They do similar studies to us, and they still think 20 to 25% of their outpatient antibiotics are unnecessary, and they are also doing these interventions. So I think we have a long way to go and lots of room for improvement that I guess, fortunately for us, I think we should probably need to keep doing this.
Okay, thank you. Another question that's come through is, do you think that this kind of intervention can be deployed in low and middle income countries where medical records are not yet digitized? And additionally, what are the minimum requirements a government should meet to implement this type of intervention?
So the quick answer to the first part of that question is there are randomized trials that have been done. They're included in the review if you want to check them out. It does work, but of course, it's built on manual review of generally a random selection of charts rather than just for feasibility purposes, rather than a complete but automated review of charts. So it can still work. The second question, I think it's fair to say that if you ask taxpayers, they would expect that audit and feedback would be happening all the time. That if the government held the data necessary to give feedback to doctors that might improve their practice, that should be expected and the norm. And instead, what we have is people, handcuffed by privacy laws and research projects needing to go above and beyond and trying to find workarounds to do these kinds of things. And that's all a bit artificial, in my opinion.
Thank you. I'll just add a quick comment from someone here that's noted that they've added a viral prescription pad in their ER, and they've gotten good initial feedback from physicians and NPs. Too early to tell if it's affected their prescribing practices. So just a comment for both of you. And I think our last question that we'll have time for today is, what do you believe is the most effective approach to public health when it comes to educating patients?
Yeah, the short answer is we don't know the answer to that. That trial or study has not been done. Is actually Noah and I had proposed a public health communication study that wasn't funded, but we'll hopefully do one eventually. There's a fair amount of data. It's not like great, randomized control data, but data that shows that public communication is effective. But that's taken on all kinds of various forms. And I don't think we know what is the most effective or efficient way to do it, but that we should be doing it probably in a variety of ways.
Okay, thank you. So I think that we've got through all our questions, which is great. And I'll turn it back over to Harpa to wrap us up today.
Thank you, Sarah, and thank you to our speakers, Noah and Kevin. That was wonderful. And I just want to share a last slide because we have more to come, and we'd love for you to take a few moments to complete a quick evaluation survey. So scan the QR code for the evaluation survey, that one on top. Then and below is the QR code to sign up for our next event, which is Stewardship with the Human Touch, Handshake Stewardship at the BC Children's Hospital. So looking forward to that one on March 25th. And so thank you all for joining us. We will endeavor to send with our emails to all registrants links to the resources that Kevin shared with us and Noah shared with us. So thank you all again. Have a wonderful day. Join us again for CAN AMS.